Yeah, I'm Lindsay Weaver, I'm the Chief Executive of Climb. Climb is a patient umbrella organisation to lots of different patients and families who've got inherited metabolic conditions. So we offer support, but also some advocacy in terms of things like gaining access to medicines and treatments. Climb's been around for 35 years, but we recently had a look at our business plan and entering a new phase really with renewed focus for patients based on an in-depth consultation that we've had with all of our members and all of our patients and families, and with all of the professionals and other stakeholders that we work with on a regular basis. So we've had a real good review of what we're doing and looked at whether or not we're focusing in the right areas and whether or not we're really having the best impact that we can on the resources that we've got. So the centre circle is about patients, obviously. So we want patients to be at the heart of everything that we're doing. So if patients don't want it, we're probably not going to do it. But we need to be listening to what patients do want and need. So every decision that we make now, we'll be able to evidence that patients have been at the heart of that. And that's really, really important to us as an organisation moving forward. And then surrounding that, we've got this core services element, which is about the support, the direct support that patients need and families need. We've been delivering this support for about 35 years. It can be anything from a listening ear right through to practical support, claiming benefits, understanding the routes that the patient should be going down or what support they should be receiving and whether or not they are. More and more there's a need for that because obviously with social care and public services being cut and some services no longer being there, I think there's a real role for charities like us to plug that gap, if you like. And our patients again telling us that that is something that they really need and want. And then on the outer circle are our other main strategic areas of focus. So we've got young people, information, making sure people get the right information at the right time about their condition, early diagnosis and newborn screening, which is a whole other area, similar sized to this area of access, and then you'll see patient access. So that's one of our strategic areas of focus that we'll be looking at over the next few years. So what is patient access? Well, our experience of patient access is on a condition called hyperphosphatasia, which is an ultra-rare metabolic bone disorder. The HPP group, as they're known, they don't have a fully established patient group in England because there are so few of them, and the condition is so debilitating and life-threatening. So Climb became the advocate for this small group of rare disease patients during this process. There is some information up there about the condition. But what's worth noting about this condition is that if it is detected in a baby, in a child at birth, it's usually life-threatening, so the child won't survive the condition. If you go on this link, it does tell you about the personal story of the child who's called Maddox, who had hyperphosphatasia, and life was at risk when he was born. And so, having read that story and met Maddox in person with his parents, it became, really important to our organisation that we supported this family and other families going through a similar situation with gaining access to this new treatment that came on the horizon for these patients. An incredible little boy who nearly died and now is, well, firm family member of Climb, I think you would say. A lovely little boy with a great story to tell. I think the most important thing about access is making sure that that success story continues and paves the way forward for other children like him. So that's important to Climb as well. So, moving on to the sort of technical aspects of getting Maddox or children like him access to this drug. We went down, Nick and Josie have done a really good overview of all of these really complex processes in terms of rare disease treatments and drugs and how they actually get to patients. And just going back briefly to what Josie was talking about, the process that we went through, which is the highly specialised technology appraisal with NICE, like one tiny part of all of these different processes, one very, very small avenue. I think they said 3 years originally would go through the HSTA. So we were really fortunate that we were able to go through this process. But obviously this is not going to be applicable to everybody. The process itself and how that's carried out is different to many of the others. But I hope that through my presentation, the principles of how a patient organisation can be involved and interact with that process will be the same. Some of you can take that away, even if you never have the privilege of going through this yourself. I'm not going to go through all of this because the process actually took 2 years and with several thousand meetings and consultations and lots of paperwork and all the rest of it, continually making sure that our voice on behalf of these patients was heard and taken into account. So it started in 2015. What they normally do is have a scoping meeting, so they work out whether or not they scope out whether or not it's worth putting through this process to begin with. And at that point, we were already told that it was going to go through the highly specialised technology appraisal. But I have been involved in other drugs where that is still in dispute. So you can, as a patient organisation, if you have a seat around the table, also influence the avenue that the appraisal goes down. So we talked before about highly specialised technology, multiple technology appraisals or single technology appraisals, and we have had input into whether or not it's the appropriate appraisal as well. So although this was a done deal, we felt we were in the right place. You can influence a bit before that as well to make sure that you're going into the right, and that is so important because it all comes down to the rarity of the condition, the population, the data that you're going to have available during the process, and that's going to really influence the outcome. So learn as much as you can about those things, I would say. Then the manufacturer made their submission of evidence to support the treatment for the use of hyperphosphatasia. And then we started on our first evaluation committee meeting. And this is where Klein were involved from the beginning. So we were given a seat around the table as an expert, if you like, as a patient expert in the condition. So we were able to provide information about the impact of the condition on patients who don't have a treatment currently, and the difference that having a treatment would have to their lives, the lives of their families, and all of the rest of it. So we did have a seat around the table from the very beginning. After a very long time, probably about 1.5 years, maybe a year, we were asked if we wanted to enter into what was called a managed access agreement. And the managed access, I found a fairly simple summary of what a managed access agreement was. But it's basically an agreement between the manufacturer, NICE, NHS England, clinicians and the patient organisation. So it's an agreement between us all. And it allows for a treatment to be made available for patients for a limited period of time, providing that during that limited time you gather further evidence on the treatment's effectiveness and benefit. So when we came to the managed access agreement, we all thought, great, we're actually going to get somewhere, we're going to reach the final hurdle, we're going to make an agreement, and then we realised, ooh, actually that's just the start of a whole other process of gathering evidence. So the access part is about getting patients access to the medicine. And the managed part is why access to medicine might need to be managed, and we've already talked about the cost. It might have something to do with the cost, it might have something to do with the fact that there isn't a whole lot of data really supporting that its effectiveness or the longer term benefits that it will have on a person. And then the agreement part is the bit where we all need to sit down and eventually agree how this is all going to fit together, which with a variety of stakeholders with lots of different perspectives and interests in this is difficult in itself. So that's what a managed access agreement is. And then we went back into the process now, trying to work out what the managed access agreement should look like and making sure that everybody who should had a seat around the table to come up with that agreement, if you like. And then it was another a year, I would say, until an actual agreement was made. They still refused the managed access agreement, and then we went to an appeal process. The appeal process was upheld, but then with negotiations behind the scenes with the pharma company and NHS England, presumably around price, the appeal meeting was cancelled and a new managed access agreement was presented, which was eventually agreed. It was September 2017 that the managed access, in July, the managed access agreement was signed off, everybody had agreed. And I think the most important thing about the managed access agreement was that it meant that the patients who are most in need of receiving treatment will have access to the treatment. And that can be really difficult differentiating between which patients should have this treatment and which ones shouldn't. And I think as a patient organisation, you do get into a situation where you really need to be very well considered about what you're agreeing to and what you as a patient organisation think is acceptable. Obviously, we want all patients to have access to a treatment that's going to help and improve their lives. But if that means by proposing that no one's going to get it, we really need to be really careful about which patients we do recommend to have treatment and which ones don't. And that can be very difficult as a patient organisation being in that position. So at Climb, we're really considered about the fact that we wanted the patients who were most in need to have access to this drug, first and foremost, under the managed access agreement. And then we can hopefully build on that over the next 5 years and get the data in place to make sure that other patients as well who are suffering from the condition can also have access. But that was our primary goal. After the managed access agreement is agreed, we then need to talk about how is it going to be implemented, and that's all of the nitty-gritty around which centres, which metabolic centres are going to be responsible for the treatment, implementing the treatment, gathering the data from the patients. This managed access agreement means that patients will need to travel to one of 3 expert centres. So everybody will be treated by a very small number of experts so that the data can be gathered and monitored, which is critical obviously to the longevity of whether or not other people are going to get to receive this drug. So we've recently met with NHS England to discuss the implementation plan, and again the role of our organisation to communicate that out to patients, I think, is the most important thing. Some of the patients who had access to drugs through clinical trial or on compassionate grounds won't be used to having to comply with the criteria of a managed access agreement. It can be very stringent. They will need to attend so many appointments, they will need to offer so much data, and they may not be used to that level of compliance, if you like, under the new agreement. However, if they don't, then under the managed access agreement rules, they can withdraw treatment from these patients. So as a patient organisation, it's really, really important that we communicate with the patient community around why it's so important that they comply with the managed access agreement. And again, coming right back to the beginning, this is so that we can pave the way so that other children can have access to this drug and that we get the right data that we need after the 5 years. So, I mean, that was all a bit convoluted, but it is. So I just thought, as sort of my final slide, I'd just look at what, as a patient organisation or as a patient group, what is your role and what are the key actions that you really need to do in order to have any impact on this process. And they're in no particular order, I typed them out really fast. But engage immediately with your community. So tell them, you know, exactly what's going on. As soon as you know, you see this on the horizon, you need to make sure that you're telling and informing the community and that they fully understand the impact of what it is. So saying to somebody, oh, there's a treatment and it's going through a technology appraisal at nice. You know, as a patient organisation, you've got a responsibility to tell people exactly what that means and the impact that it can have on them. This is life-saving or life-changing and they need to get behind it. We promoted questionnaires and studies of relevance, so there were some specific metabolic bone studies which we felt would provide a lot of data which we encouraged patients to participate in very early on. We tried to work strategically with the manufacturer, so by understanding their objectives and their data. Engage with all stakeholders. With our managed access agreement, we didn't have any adult clinicians, any adult HPP clinicians involved from the beginning, and that was a real loss towards the end of the process. We really realised that that was missing from the decision making and that adults hadn't been fully advocated for on the clinician side. So again, going back to the beginning, you need to make sure we engage with all stakeholders. Gather support from other patient organisations. They're not your enemies, they're your friends. If they have an interest in this stuff, get them to join you in what you're trying to do. And that's the most important thing I think I've learned through this process. That we are all in this together and that we need to demonstrate strength together. And I think that was really, you know, we had support from Brittle Bone Society and other organisations who were there to support and just to add extra leverage really to our voice. And if you can, try and understand the NICE process and have a lead to monitor the process. So you wouldn't believe the administration involved in being, you know, and for some patient organisations that's really hard because you haven't got anybody there full time doing all of this stuff. So draw on resources, get people to attend meetings, make yourself visible, be part of the process, turn up to things. And try and keep up with any other changes. So, you know, Nick and Josie have highlighted today, this is an ever-changing scenario and you just get used to one avenue and then the whole thing completely changes again. So feed into consultations, put your voice forward, join together with other patient organisations and keep participating even when it's not directly affecting your condition or your disease. So that would be my advice, if you can call it that. So that's it for me. Thank you.